at this point in time, in the program, I would just like to introduce our first guest speaker, and she is going to help us to meet the objective of and the principles of basically what the BFHI is all about. So let me make this lovely introduction of Mrs. Lilith Melbourne Bailey. What a name, and I'm sure she's going to live up to that name. So Mrs. Melbourne Bailey has spent in excess of 20 years of her life experiences, using all of her personal experiences to basically assist patients in the communities and helping them to overcome such nutritional related issues and help provide them with all the necessary support that they require. Mrs. Bailey also understands that no single approach works for everyone, as we all know. So she continues to educate herself on emerging trends in order to provide the most appropriate programs for the patients in public health settings. And she has worked in areas such as HIV nutrition, the Baby Friendly Hospital Initiative, infant and young child feeding, and chronic disease management, to name a few. With all of her experiences, she now serves on the National Infant and Young Child Feeding Committee, as well as the St. Mary's Infant and Young Child Feeding Committee as the chair. She has a bachelor degrees in dietetics from Northern Caribbean University, and she also holds her master's degree in public health with an emphasis on public health nutrition, which she recently completed. And I'm sure she's going to work us up to a hungry appetite with all of this nutritional background. Over to you, Mrs. Bailey.
All right, thank you for having me. Good evening, everyone. I am just going to ask you for giving me co-host privilege so I can share my screen.
Go ahead.
Just give me a minute. I'm trying to get to the slide share.
Go to the bottom of the screen.
No, I'm coming.
Yeah. All right, there you go.
The toolbar was giving me a little. All right, so this evening I will be sharing with you about the Baby Friendly Hospital Initiative, which is a part of the global standards. Just give me a minute, my screen is not moving. All right, at the end of this evening's presentation, you should be able to know, you will be able to know about the WHO UNICEF Global Strategy for Infant and Young Child Feeding. We will be outlining the Baby Friendly Hospital Initiative, and we are going to list the 10 steps to successful breastfeeding. Overview. So all healthcare workers who care for women and children during their postnatal period and beyond have a key role to play in establishing and sustaining breastfeeding. Many healthcare workers are not able to fulfill this role effectively because they have not been trained to do so. Many mothers also have difficulty breastfeeding from the beginning, and healthcare practices in many facilities hinder this process of establishing breastfeeding. However, even though mothers who initiate breastfeeding satisfactorily often start supplements or stop breastfeeding within a few weeks of delivery. This may result in malnutrition, which is an increasing problem in many countries, including Jamaica and the wider Caribbean. It has been estimated that improved breastfeeding practices would prevent about 823,000 annual deaths in children younger than 5 years of age. All right, now we're going to look keenly at the goal of the global strategy. And the first goal states that it will improve the nutritional status, growth and development, health and survival of infants and young children through optimal feeding practices. It also supports exclusive breastfeeding for 6 months, followed by timely, adequate, safe, and appropriate complementary feeding. Breastfeeding should continue for up to 2 years and beyond, and support for maternal nutrition through social and community support initiatives. So those are the goals of the global strategy. The Baby Friendly Hospital Initiative was launched in 1991 by the World Health Organization and the United Nations Children's Fund, UNICEF, with the goal of protecting, promoting, and supporting breastfeeding in facilities that provide maternity services. So these were the reason why WHO and UNICEF always support the BFHI, because they want to support the facilities that promote breastfeeding. The Baby Friendly Hospital Initiative is a joint WHO-UNICEF statement, which was published in 1989. So the 10 steps became part of the Baby Friendly Hospital Initiative in 1991, and it was updated in 2009. However, in 2018, the 10 steps was revised, and which continues to be valued throughout the world as a basis for certification and training as it relates to Baby Friendly Hospital Initiative. The Baby Friendly Hospital Initiative has been shown to, 1, increase rates of exclusive breastfeeding, reduce the incidence of gastrointestinal disease and atopic eczema during the first year of life, and it also improved children's IQ and academic performance. But despite its proven benefits and reliance to current global health goals, the BFHI has suffered from waning political and financial support in recent years. And I'm sure you can attest to that, whichever country you're from, but we here in Jamaica can attest to that, that we have been suffering as it relates to political and financial support. Recertification processes are not in place in most countries to ensure that BFHI standards are maintained at facilities that may have been certified long ago. And we too are experiencing that in our country. There is substantial evidence to show that the 10 steps improves breastfeeding rates. While BFHI focuses on breastfeeding support, it also provides for integrated care to support all mothers, including those who are not breastfeeding. So BFHI supports women living with HIV. All right, so with the new 10 steps, we have 2 sections. The 10 steps is now divided into 2 sections. One has to do with administrative and the other has to do with clinical competencies. So whenever you're considering, whenever the facilities are considering to be certified baby friendly, there has to be a policy, there has to be a hospital policy, there has to be staff competency. We look at antenatal care, we look at care right after birth, support mother with breastfeeding, it looks at supplementing, rooming, responsive feeding, bottles, teeth, and pacifiers, as well as discharge. So we're gonna go a little closer, I'm gonna look a little closer at the 10 steps. So the first step states that, so number one now has 3 sections. So the first 1A states that the facility should comply with the International Code of Marketing of Breast Milk Substitutes and the relevant World Health Assembly resolutions. The facility should have a written infant feeding policy that is routinely communicated to staff and parents, establish ongoing monitoring and data management systems. So those top 3 are critical as it relates to baby-friendly hospital initiatives or being certified baby-friendly. Number 2, ensure that staff have sufficient knowledge, competence, and skills to support breastfeeding. So number 2 speaks about training. So right here, we know that training is very, very important as it relates to getting a facility certified as being baby-friendly. So staff, at least 80% of staff must be trained in order for a facility to be certified baby-friendly. Number 3 says that we are to discuss the importance and management of breastfeeding with pregnant women and their families. And this discussion starts at the antenatal clinics. So this is where the discussion starts. Number 4 says that we should facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. So I know that somebody's going to deal with challenges, so I'm sure they're going to come up with some challenges as it relates to skin-to-skin contact. And this part is very essential as it relates to starting breastfeeding. Number 5, support mothers to initiate and maintain breastfeeding and manage common difficulties. 6, do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. Number 7, enable mothers and their infants to remain together and to practice rooming in 24 hours per day. And we all know what rooming in is, baby and mother staying together. Support mothers to recognize and respond to their infant cues for feeding. So the mother should know the signs, know the hunger signs, know when their baby is hungry, so that they will feed the baby when the baby is hungry. Counsel mothers on the use and risk of feeding bottles, teeths, and pacifiers. And this is also a challenge for us as it relates to breastfeeding, exclusive breastfeeding. Coordinate discharge so that parents and their infants have timely access to ongoing support and care. And this is where our support groups come in, our community support groups. This is where they will get ongoing access to care. All right, so I'm gonna look a little closer at training. So when it comes to training, since training is so crucial as it relates to a facility being certified baby-friendly, all health workers who care for women and children during the postnatal period and beyond have a key role to play in establishing and sustaining breastfeeding. And so many health workers cannot fulfill this role effectively because they have not been trained to do so. I can say right here in Jamaica, we are trying our best to train as much persons as we can in the community. We always try to have ongoing training because we know that staff rotation is very, very popular, is very, very common. So we try to keep up. But with COVID now, we are facing some challenges. And I know that will come up when challenges are being discussed. Information on how to feed infants comes from family beliefs, community practices, and information from health workers. Advertising is another issue, and commercial promotion by food manufacturers is sometimes the source of information for many people, including families and health workers. So when it comes to the baby-friendly hospital initiative, we know that the manufacturers of infant feed, they are not allowed to do any form of education to the patients, but they are allowed to educate staff And so there are several things that we should not do based on the code. There are so many things that are stipulated. We should not take any gifts from them. We should not have their posters in our facilities. So there's a lot of things that have to be done in order for your facility to be certified baby friendly. It has often been difficult for health workers to discuss with families how best to feed their infants, owing to the confusing and often conflicting information available. And that is why training is important, because we need to clear up all those conflicting information so that when we go out and we are talking to families about breastfeeding, then we have evidence-based information to share with them. Little time is assigned to communication and support skills for breastfeeding and infant feeding in the pre-service curriculum of doctors, nurses, midwives, or other healthcare professionals, or even other professionals on a whole. And so this is so true when it comes to talking to breastfeeding mothers or pregnant mothers. We don't have enough time in the clinic to really discuss some of the things that we want to do. But I can say that right here in Jamaica, what we do, we try to make education a part of our clinic session. So education is the first thing that should be done with the patient before the midwife starts seeing them, or the public health nurses. The updated training course, so we have an updated training course. So even though you were trained before, we will still be doing refresher courses because there's an updated training and it's with the revised 10 steps. And so this is what we will use going forward as it relates to certifying hospitals or maternity facilities, certify them as being baby friendly. So the new training course, that is what we will use from now on. So even though some persons might be trained already, there will be a refresher course, and for those who have not been trained, you will be trained using the new course. Certification, just a quick thing about certification. A hospital that is designated as baby friendly must fully implement the 10 steps to successful breastfeeding. And remember, these are a summary of recommendations of protecting, promoting, and supporting breastfeeding, and which is a special role of maternity services. All right, now we're going to take a little look at the Jamaican situation. A total of 18 government hospitals and 4 private facilities provide delivery services to 40 to 50,000 women who give birth each year in Jamaica. The Ministry of Health commenced the Baby Friendly Hospital Initiative in 1996 and continued in 2001, certifying 10 facilities in 4 parishes over the period. And these 4 facilities were Victoria Jubilee Hospital, Spanish Town, Linstead, Princess Margaret, Cornell Regional, Andrews Memorial, Doctors Hospital, Bustamante Hospital for Children, University Hospital of the West Indies, and the Faith Maternity Center. And of those facilities, only Princess Margaret is the only facility that remains baby friendly. And these facilities, 58% of all births are done in these facilities. So this is why these facilities should be certified baby friendly. A special appraisal was done in 2008, consisting of the analysis of practices which encourage or hinder breastfeeding, and it indicated that there was a deterioration and that there were necessary steps needed for recertification. In 2001, UNICEF-supported evaluation showed that most health workers were not trained. Currently, I can proudly say that we have 5 facilities that are now certified baby friendly. Princess Margaret, which was done in 2015, Alexander Community Hospital in St. Anne, Lioneltown Hospital in Clarendon, Port Antonio in Portland, and Port Maria Hospital in St. Mary. So we have 5 facilities in Jamaica now that are certified baby friendly. So in closing, I want you to leave this afternoon, this evening, with this in mind, that the Baby Friendly Hospital Initiative was established to equip health workers who care for women and children during the postnatal period and beyond with the requisite skills and competencies so that they can effectively fulfill their role in establishing and sustaining breastfeeding. So those are some of the sources that I gathered my information from. Do you have any questions? And I have one question I want to ask before you ask, and you can give me your feedback. What will you do to protect, promote, and support breastfeeding? Any questions?
Unmute your mic, Marlo.
I want to thank you, Mr. Lily F. Melbourne Bailey. Are you gonna get? You're not hearing me?
Go again.
Thank you kindly for your presentation. I'm hoping you're going to wait for the responses because they're going to be numerous by the time we get to our question and answer session.
Okay, I will wait, yes. No problem.
So I hope you don't run away. The answers should be quite interesting. But I must say you've gotten us off to a really good start. You've given us quite a bit of food for thought, and you've made us very aware that this journey is certainly not an easy one. And of all your facilities, you gave us like 22 in Guyana, not Guyana, I'm sorry, Jamaica. 5 of them being baby friendly certified. That shows the level of work that we have to put in and be constantly doing to really make sure that we provide the optimal nutrition for our infants and keep our institutions baby friendly and make sure that our babies and mummies are well taken care of at the time they most need it. Quite a task ahead for us as healthcare workers. We're quite a few here at 279, so I'm sure that we can be all a drop in the river to make sure that we do our part to help with this baby-friendly certification across the region. So we're going to move nicely into our second presenter. Our second presenter is Ms. Deborah Thomas. Ms. Deborah Thomas is a national coordinator. She is the national coordinator. She works in the national coordinating unit, and she is the director of women's health in the Ministry of Health in Trinidad and Tobago. Deborah Thomas is a registered nurse with in excess of 30. Just a minute, Deborah. 34 years experience, and she is the holder of a master's degree in public health from the University of the West Indies. Part of her past portfolios include the baby-friendly coordinator and operating theater manager. This is Charmaine Williams. I'm asking you to mute your mic, please. Charmaine Williams, could you please mute your mic? Thank you so much. Like we were saying, Deborah Thomas, she has part of her past portfolio included the baby-friendly coordinator and operating theater manager at Mount Hope Maternity Hospital in Trinidad and Tobago. And she has also been the district health visitor and the primary care nurse manager at North Central Regional Health Authority. She is known to be very passionate and in her response to life and has a strong advocacy for humanity. Deborah is a licensed midwife with an extensive experience as a Lamaze instructor. and she is recently trained as a trainer for the Baby Friendly Hospital Initiative and as a BFHI assessor by the WHO and Pan American Health Organization. In 2018, September, Deborah became the first national breastfeeding coordinator at the Ministry of Health, and she was instrumental in the completion of the first ever national breastfeeding policy of Trinidad and Tobago. Her goal is to synchronize the united response, which is needed regionally to protect, to promote, and to support breastfeeding for the health of all mothers and babies. Over to you, Mrs. Thomas.
Good afternoon, everyone. It's a pleasure being here. And I just want to follow suit on the heel of the first presenter. This evening, my objectives are simple: to give a history of breastfeeding in Trinidad and Tobago, to give you an overview of our present situation, to share with you the challenges that we are now facing, and look at how we can complete our assignment. You can go to the fourth slide, please. Just to give you a history, the government of the Republic has shown support for breastfeeding even before the Global Action Plan was introduced. And those who would have been, even before my time in the nursing profession, could attest to the presence of wet nurses at our nation hospital. You can go to the next slide. In 1977, we were graced with the informative breastfeeding support group, which we commonly call TIBS, and they are a civil society group who began to mobilize to get the support for breastfeeding in Trinidad and Tobago. How did they do it? They collaborated with healthcare workers, wrote articles, so you would have seen their newsletter at all of our health institutions, and they became part of a national breastfeeding committee, and they began work on the policy. And you would have heard in the profile that the policy came into being just August 2020, but our policy was actually in the making for 39 years. And so people like Marcia Rollock can attest to this because they were part of that process. You can go to the next slide. In 1990, just to give you a history, and I don't want it to stay there because our first presenter was quite comprehensive in laying down that the foundation of how it came about, the BFHI came about. And so we looked at the fact that in Florence, Italy in 1990, people gathered from all over the world in response to what was taking place, where you realize that babies were dying, quite avoidable deaths from gastrointestinal diseases, all because of what was being fed to them. And so there was a need to gather support and come up with a global strategy. And right there, we became part and parcel of that strategy to make sure that our citizens were being well taken care of, our mothers and our babies, and offer the best nutrition possible. Right? So we became a member state and signing on as part of the Innocenti Declaration. There we began to adopt the Global Action Plan and to continue mobilizing to implement breastfeeding at all of our hospitals using the strategy which was provided of the BFHI, which was the 10 step to successful breastfeeding and the code. Fortunately for us, our civil society group partnered with the Ministry of Health, TIBS, and work assiduously to ensure that our hospitals start in the mode of becoming baby friendly. And we experienced one success, which was the Sandy Grande Hospital. Unfortunately, we were not able to maintain this accreditation. Right, so presently there are none of our hospitals are accredited, right? How are we supporting? In support of what needed to be done, there was a national response from the legal aspect in terms of looking how we can bolster support for the international code. And I must say at this point, our civil society groups have really worked. TTAM and TIBS is now back, right? And they worked in terms of mobilizing along with the Ministry of Health to get some legal strengthening in terms of the Food and Drug Act. And that dealt specifically with the labeling of breast milk substitutes. So we do have a bit of legislation to help us in support. In 2017, the cabinet granted approval to improve maternal. We were having challenges in the area of maternal, infant, and neonatal mortality. And so our government response was to come together and do an integrated neonatal, maternal, adolescent strategic plan for the period 2017 to 2021. And therefore, as part of that, and the run up to that, setting the foundation and the stage for that, they saw the need to implement that a national coordination from the level of the Ministry of Health. And this was attached to the Directorate of Women's Health. And I assume as the manager in 2018. All of this, as you know, is part of the nine key responsibilities of the BFHI, recently revised in 2018. There are 9 key responsibilities, one of the first being national coordination. So the government went along in terms of getting that done. To do that, we also needed the support of our technical cooperation. And so PAHO has been working with us to provide that technical cooperation. And that technical cooperation deals with the training of our trainers, as you will see later on in the presentation. But also we are on the road to securing a human breast milk bank. And so that formed part of the technical cooperation that started way back in 2016. And so in 2017, there was a delegation that went to Brazil to start working on the formulation of the human breast milk bank for Trinidad and Tobago. We needed to get a national response. And so not just national, but a sub-regional response. And in 2018 in Jamaica, there was a 5-day training in which Trinidad and Tobago participated. There were members of the different regional groups there. I know people from Jamaica, Antigua, Barbuda, St. Kitts, and a whole host of other countries came together, and we were trained for 5 days in the recently revised BFHI. In Trinidad and Tobago, our health system is managed really by 5 regional health authorities, and that is our public health system. We have a public health, we have private health. But each regional health authority provides maternal and child care services. And because of this, though, we had to focus on getting the nurses, the midwives, the district health visitors, and even other members of staff to participate in training for baby friendly. One of the things that we had a serious problem with in coming into office, looking for data, breastfeeding data, was a problem. There was no repository for data gathering. So what you would find is that people would gather information at their local health centers in the primary healthcare and in secondary healthcare, but there was not anybody bringing that data together. The Directorate of Women's Health now had that responsibility of collecting data, anything that had to do with maternal, neonatal, infant mortality, anything that had to do with child health. We had to collect that data. And in collecting that data, we realized that 91% of our births were occurring in the public health system. We also were able to gather the data to the tune that 95% of our pregnant women would at some point in time receive care in the public health sector. You can go forward with the slide. Go on. Next slide. Where did we gather data from? Because we didn't, before the directorate, somebody needs to mute their mic. So can you go back one slide up for me? Thank you. Right. So before the creation of the Directorate of Women's Health, we depended on the multiple indicator cluster sample to provide data on breastfeeding and anything else in terms of maternal and child care. And so in 2006, when that sample, that survey was done, we realized that 41% of our women were allowed early initiation of breastfeeding, but only 12.5% of them exclusively breastfed for 6 months. When it was done again in 2011, we realized that there was only a slight improvement of the breastfeeding rate, exclusive breastfeeding rate, from 12.5 to now 21.5%. And so that data, however, was not collected for a 6 months exclusive period, but really for a 5-month period, right? So in 2020, we got to the business. You could go on to the breastfeeding form slide. Next slide. Right. So in 2020, we know that we needed to put systems in place to gather data, because if you have to go on a journey to improve where you are going, you realize that you had to know where you're jumping off from. What were the figures we're dealing with? How many of our women were actually breastfeeding? At one point, were they breastfeeding, stopping breastfeeding, mixed feeding? How long were they exclusively breastfeeding for? This information was not available to us. And so to gather this information, we created 3 forms, forms A, B, and C. And we created these forms in line with the 10 steps. Yes, you can go to the next slide. So you would find that form A dealt with the step 3 in the 10 step and dealt with the antenatal period. Form B dealt with step 4. And so we had to look at what was happening with the initiation rate for breastfeeding. what was happening with uninterrupted skin-to-skin contact? Were women given the opportunity to allow their baby to do the crawl? And so the steps needed for breastfeeding to be successful, we had to look at these. And these forms were positioned at different places. So the Form A was placed in the antenatal clinic, both in primary and secondary care. Form B is placed in the birth department or the labor or the delivery unit. And Form C goes back with the woman after delivery, after not delivery, after discharge, to follow them up for 2 years and more. So you could go to the next slide, right? So this slide, you can go to the next slide. Right. These forms were created both in hard copy to make their way to from primary care to go with the woman and attached to her antenatal record to the birth department or the antenatal ward, wherever she was admitted. And it would be joined now by Form B, right? And when she is discharged and goes back to clinic, now in the child health clinic, they would start on the Form C. Now, they were done in hard and soft copy. And recently, the ICT division at the Ministry of Health, they did a digital online copy. So this can be done. We can get the information coming back to our unit at the National Breastfeeding Coordinating Unit in real time so that we can look at data and plan ahead. Next slide. Training, an important component. And I want to put in a plug here. We are in a Caribbean midwives conference. And I don't know if it happens in the other territories, the other countries, but sometimes you realize that training for breastfeeding comes as an afterthought at the end of a course. So you train your registered nurses, and at the end of the program, you're 15 breastfeeding training. You train your midwives, and when you finish the whole syllabus, then you're 15 breastfeeding training. You train your DHVs, and you have to fit in. And in order for us to bring in any real change, we have to start seeing the training of our nursing and medical staff as an important component in pre-service. It must factor right up there with all the other things that we see as important and not just be put down there as an afterthought. Oh, you know, they have some time now after exam, so let us try to fit in that week. No, we have to take a different response if we are asking them to do what is required of the 10 steps, right? So in order to do that, we had to make available trainers, again, with technical cooperation from PAHO WHO. The revised 2018 course was done. And so we started off with training 23 of our healthcare professionals. And we could not leave out our civil society group. And so we had 2 members of the civil society group. And if you look closely at the picture, you would realize that one of our trainers is a male, right? So we had our first male trainer in the BFHI. This training must be ongoing. It must be sustained. And if you look at the recently revised training, you will realize that additional components was added to this training. You now have a competency factor. You now have you have a sick baby, you have a preterm sick and low birth weight baby component. And so training must be ongoing. And so to continue the training and maintain these competencies, what we have committed to do is not just leave the 25 persons we train, but we reach out to trainers who were formerly trained under the old BFHI and ask them if they would come in and again go through retraining so that we could bolster the capacity of trainers that we have. And because we had a plan, not just to train in hospitals, but to now spread our training to the community. And I'll tell you why. So every year since in 2020, and in this year we had to do it virtually because of the COVID. We bring our trainers back in one place and do refreshers with them so that training could be standardized. One of the things that we met is that the training was not standardized. Everybody was doing training according to how they see fit. And so once everybody was on the same page with training and maintaining that, we know that we were going to increase and improve the quality of training that mothers were getting at the clinic and that the staff were getting so that they could tell our clients the right thing. The training included training of assessors. And so we got together with some other groups, hosted a training for 11 persons, some from Grenada, some from Guyana, and from Trinidad and Tobago, so that we can have a cadre of Caribbean assessors. Next slide. We must be saying the same thing about breastfeeding. Too often what you found is that there was not a standard. So somebody will tell you something about breastfeeding. Somebody will say something different. In fact, when we did our audit, we went to every one of the health facilities and I asked them to provide for me a copy of the literature that they were giving to the mothers. And you would be amazed at the different amount of information, the literature that women were getting. And so we had to start now a public campaign. So with one voice to give the same message on breastfeeding. And that had to come from a national level. So we have been bombarding the airwaves and encouraging other people to bombard the airwaves with one message through the social media, radio, television, and interviews. Again, with that technical, next slide, that technical help that we're getting, we also needed to provide the information for both staff and patients. And so we got that technical assistance to provide the new 10 steps, because what we met when I came into office is the old 10 step was still there at all of our health facilities. So we got assistance to provide the new 10 steps. We got assistance to standardize our literature. And so if you look closely, what we have done, next slide, what we have done is we have taken the 10 steps and make it look as relatable to what our Caribbean people look like. So we literally took the pictures of the members of staff from our different regional health facilities and our patients, different categories of staff. We got permission from PAHO WHO to not interfere with the text, but just to make the 10-step look as lively, as vivacious as we Caribbean people, so that when patients and staff look at it, they can relate to it. We also got funding from the IDB to produce brochures, flyers, banners, and to purchase training tools such as anatomical dolls. I always have trouble pronouncing that word. Next slide. So you missed a slide. Here we started also, go back one slide, please. Just go back one slide. Right. We started also working on creating our own brochures. So you could go now to the next slide. Our own brochures. And these are available to you if you want any of them. It is online. You just go to the Ministry of Health, Directorate of Women's Health website, web page, you scroll all the way down to the breastfeeding section, and you will find that we have a breastfeeding series, right? There are 9 brochures there, benefits the mom, benefits the baby, and we looked at the questions that women asked the most in terms of what they needed, and we try to meet those needs. And I am saying to you, in a very short time, what you'll find coming out of that on that same web page is that we have created now a breastfeeding book. And in that breastfeeding book, we have gone from not just dealing with babies in the exclusive breastfeeding period, but we looked at complementary feeding and provided measurement standards and recipes that mothers could use. So very soon you'll get it in hard copy, you'll get it in ebook, and even a braille version will be provided so that the blind community will not be left out. Next slide. We needed to partner and find places that support breastfeeding. And this is one of the agencies, government agencies, where they provided a safe space to enable breastfeeding, right? And so this is a breastfeeding room. The nurses and the midwives at our regional health authorities also went ahead. And this is one from Tobago. This is a breastfeeding room in Tobago. Also went ahead, and you'll find that at each regional health authority, at some of our primary health facility, but in all of our secondary care facility, that you will find expression or breastfeeding rooms, not just for staff, but also for patients, right? So we want to move on. Public health education and breastfeeding information. On our next slide, you'll see that we had to move with the times. In standardizing the information, we had to put it in places where persons can see this. And where do people go to information? Yeah, on the social media. So we have to move right along with the times in putting information out on the social media. And I want to encourage you as Midwives Association, do that. Come on, just get together and do a lot of stuff. I know our local group do their part in making sure that our mothers are well trained and prepared for breastfeeding up at Titam. I know out of the area in Couva, they do their bit, right? But we need more. We need you to put messages, and we need a Caribbean response. We don't just need a local response because we are small in numbers. But if we get together as a Caribbean and we mobilize these messages and we keep bombarding the social media, then women will get it. Then the messages will get to them, right? What are some of the other challenges we have? The need for additional legislation. You can go to the next slide, please. Additional legislation. We know we're getting licks with that code, violation of the code. I don't know what is happening in your country, but we have a watchdog group that constantly write to the ministry that says, listen, we see in billboard, listen, in the cosmetic store, we see in banded offer, listen, doctors are telling and nurses are telling people, no, you don't have to breastfeed for that exclusive period. You have to mix feed. You have to. We need additional legislation, right? We need the support of each other. We need to all be saying the same thing as healthcare professionals. We confuse people by one saying one thing and the other saying something completely different, because we might have different agendas, right? So we need to be saying the same thing, having one head and one mind and working together as one team. We need to provide the public with accurate, relevant, and up-to-date information, especially on complementary feeding. You see the 1 year, right? I'm not going to go anymore. You know what I'm talking about. So we need to provide, right, information. When it comes to the violation of the code, we have to make people become responsible for their actions, right? For those who openly violate the code, even after they have been trained in the BFHI, there must be some kind of consequence to the action of those who wantonly violate the code. And I'm talking about healthcare professionals now, right? We need to create that supportive, enabling environment for mothers returning to work. We need to look at our Maternity Protection Act and begin to mobilize a united response to saying, yes, women need more time at home with their babies. If we are saying exclusive breastfeeding for 6 months, then we must provide what is needed for them, right? We must continue to distribute localized information. A lot of times, every time people have to look for information, they go on the internet and take information that is foreign to us. We need to strengthen our data collection, and I told you that we were in the process of doing that. And so, and in August, what we started was a year-long campaign, a competition among all of the RHAs in terms of how do we get to accomplish our global goals of 40% exclusive breastfeeding rate by 2022, 50% by 2025, 70% by 2030. How do we do that? We need to now look and monitor the data. We need to know what quality of training are we doing as well, right? How do we complete this assignment? First, you need policy. You always need policy, because there must be a springboard for you to jump off from. You must have a point of reference. And so that was big. And we want to put our hands together for those who started the process. I know Deborah was there. I know Marcia was there. There are some names. Some have gone on and all. And so today we are proud to say we do have a national policy. We have been preparing all of our health facilities for ongoing assessment. And so every week we meet with our breastfeeding coordinators to give them the support, to give them the training, to give them the encouragement, to encourage them to bring strategy, to mobilize their staff. At the end of the year, who will win this competition in terms of who has increased their exclusive breastfeeding rate, and not just increase it, but who would be able to sustain it, so much so that when it's time for the assessment, we will as a nation be making sure that our babies are born in hospital that are baby friendly certified. We must reach our targets. And so, ladies and gentlemen, if there are any gentlemen, I'm sure my director would have dropped in at some point. I thank you for giving me this opportunity. I enjoyed it immensely. Thank you.
Mrs. Thomas, quite an impressive presentation. You have raised the bar so high. Your words have not gone to waste on the 338 participants that we now have. There's so many persons eager to get on board to make sure that we rally for the Maternal Protection Act, to make sure that there's a level of accountability in all of us as we journey along the BFI journey, and make sure that we are fully compliant with the code, the International Code for Marketing the Breast Milk Substitutes. And we would certainly want to be a part of some of the data collection, that the information that gets out there to John public is accurate, it is of a unified voice, it is spoken and is evidence-based as we go out there and practice. And I want to thank you so kindly for your words that have certainly intrigued us all and given us a lot of food for thought. And I'm sure you can wait for those questions, because like you said, there's a lot of training to be done. And I absolutely love how you took that poster and you made it your own. And this is what I'm talking about, the power of the nurse within us, that we move off and we do so many things that are so unique to bring it home. So I want to thank you, Mrs. Thomas, as we gradually slide now into our Barbados presentation from Mrs. Marita Harris. She is going to bring another perspective of the journey of the BFHI from a Barbadian perspective. And Mrs. Harris is a midwife. She's a PAHO consultant. She is a retired senior sister from the Women and Children Directorate, nurse midwife of the Queen Elizabeth Hospital. Mrs. Harris is an assistant with the PAHO division for BFHI in the region. She was with the hospital from the inception of the BFHI journey, and she was certainly instrumental in the recertification of Barbados in 2017, and she assisted some of the territories in the region, such as Grenada, in achieving their BFHI certification, as well as St. Kitts and Nevis, and they are also on their way to BFHI certification. Mrs. Harris was one of the founding members of the Caribbean Regional Midwives Association, and she was secretary to the CRMA for 2 consecutive terms. She is also a member of the regulation committee at present, and she has served on that regulation committee also for a period of 2 years. She is also a trustee to CRMA, and we are going to invite Mrs. Harris to give us a view from a Barbadian perspective. Over to you, Mrs. Harris.
Good evening, and thank you, Marlo.
You're welcome.
I'm going to be building on what was said before, but remember, we are now the mothers of the baby friendly, because we were baby friendly since 1998. Let's give a background. The Baby Friendly Hospital Initiative, as we call it, BFHI, was launched in 1991 by WHO and UNICEF. And the aim, as stated before, and this is reinforcement, it was to protect, promote, and support breastfeeding in facilities where maternity services were provided. The aim of the global strategy for the infant and young child feeding was to improve through optimal feeding the nutritional status, growth and development, health, and thus the survival of infant and young children. It supports exclusive breastfeeding for 6 months with timely, adequate, safe, and appropriate complementary feeding while continuing breastfeeding for 2 years and beyond. It also supports maternal nutrition, social and community cooperation. So we need everyone on board. We have leadership, which is WHO, UNICEF, and WABA. So in 1981, there was an International Code of Marketing of Breast Milk Substitutes. We had to put a code so that persons out there practicing will know exactly what the code will speak to, what we can and cannot do. In 1990, an incentive declaration on the protection, promotion, and support of breastfeeding was initiated. So the Baby Friendly Hospital Initiative started And the 10 steps of successful breastfeeding was handed down like the 10 commandments Moses took from the mount when he came down. The WHO and UNICEF Global Strategy for Infant and Young Child Feeding and the Comprehensive Implementation Plan target is by 2025. The Queen Elizabeth Hospital, and I will give you the background because that is one hospital we have in Barbados and we are baby friendly. We did a survey in 1969 and again in 1981. And what it showed that there was a declining trend of mothers to breastfeed their infant. In 1969, 75% of mothers breastfed for 3 months and 52% up to 6 months. In 1981, only 45% breastfed for 3 months and 17% for 6 months. This decline was evident on the obstetric department, where formula was readily available to mothers. In addition, persons were coming to the ward and distributing formula to mothers, promoting the formula as better than breast milk. In that period, we had assigned to the department what we call a milk kitchen. So every baby born, we catered to mix milk for 24 hours. So we made sure that there was enough feed. So there was no need to breastfeed because we were getting lots of money off the free samples. The persons were coming in and giving the mothers the samples, and we were benefiting, the hospital was benefiting from making sure that we purchased the milk at a lower cost. So we were really into the formula, right there, all midwives into the formula. A further survey then was done in 1992 on mothers or children under 1 year of age, which indicated that by then we were on our way, though 98.3% had been given some form of breastfeeding and 75% were still breastfeeding at the time of the survey, but the actual age of the infants were not given. So what did we do? In 1992, we sent 1 senior sister and 2 midwives up to the Philippines. What they went up there to do is to look at the principles behind how to make the hospital baby friendly. What would it entail? What we need to do? How we need to
Me, I didn't talk to she because she would tell she
And we
tell
did.
people. No, so rubbish book Marguerite and Marguerite book that drama.
In 1993, the motion to become baby friendly started. So they came back, and when they came back, they had to put things in place so that with only 1 hospital, it probably was not a hard decision because we only had 1 hospital, but it was to sensitize everybody now in Barbados to this new initiative, Baby Friendly Hospital. So in 1993 to 1998, we started a massive training. And you understand from the previous presenters how important it is to train. So when we started the training, we started with the Caribbean because when we went up to the Philippines, there were other Caribbean countries who joined us there. And we came back and we had the big workshop in Barbados at the Barbados Community College. And we trained persons from all the Caribbean countries. And then Barbados started on their own initiative. And there's a lot of information that was given to us. We had the trainer or trainers manual, we had the trainers manual, the participants manual, the setting up the hospital, all the necessary things to make this hospital a baby friendly hospital. And we had to use the 10 steps. So this is the Queen Elizabeth Hospital path. It was designated a baby friendly hospital then in 1998. Journey started from 1992. We finally got it in 1998. We had a successful reassessment in 2002. And in 2012, because we can either go 2 years or 5 years for our reassessment, but it calls for a reassessment because as you get new persons coming into work and you get new protocols being put in place by the World Health Organization, then you need to really retrain and refresh everybody. So in 2012, an awareness campaign began. And 2014, there is a self-assessment tool in your manual, and we use that opportunity to see where we were at and what we would need to do. And it was completed, and then it went off to PAHO to decide if we were on the right track. And then in 2016, the assessment, further recommendations were made. Because when we applied to PAHO, Ms. St. Hill was one of the persons who assessed us, not working in the department. She was allowed to go out and look and see what we were doing and if we needed any further implementation. And that was done. And in 2017, we did our assessment and we finally made it. We were successful. Our other assessment should have been in 2019, but because of COVID, we have not started our journey, but we still have time. We can go for the next 5 years, which should be after 2022, we will start to plan our way forward again. So the global strategies was really our vanguard, and these are where our challenges came. Because as a poor country, we know that people out there want to give us milk and want to give our parents milk and things. So it prohibits us from taking free samples. There was no free supplies to hospital to the individuals, such as the health professional. No, we could not accept anything from pens, bookmarkers, anything anybody want to give us, as long as it had initiation of a formula attached to it, which would be Nestle or one of those, we could not take it. So that was very tough for us. Small gifts such as pens, prescription pads, growth charts, calendars, posters, and less expensive medical equipment. You know how they have the money and they were getting to see how much they can give. But if you're going to be baby friendly, you have to say no to it and try not in your utmost best to facilitate it, because then you'll be breaking the code. Large gifts such as incubators. We know we need incubators because incubator costs $65,000. And if a company can give an incubator, a milk company, how could you say no to it? But you have to say no to them, because at the beginning they're on with us and we explain to them why we can't take their little perks, and they should understand in order for the country to be as one hospital to be baby friendly, we definitely need to watch this these things that they come with and make sure that we abide by the code. No fridges, no air conditioned units, no computers, nothing of that sort. Gifts of professional services such as architectural design. Yes, will come and like to beautify the obstetric department. We know we will like the rooms on the walls looking nice, lovely drapes and things, but we have to say no to it. We are tired and we're all burnt out. They can come and offer us holiday trips. They can give us electrical, a microwave for the ward, all things like that, but we have to say no to them. Sponsorship of the hospital, clinics or project have workers association. So Barbados Nurses Association, they know that we are non-profit and they can put some money in with us and we'll be able to spend it on the nurses, but we say no to it. Funding of research grants and salaries, we have to say no to that as well. Support to attend professional events, yes. Having something going on and we need a little funding, but we have to say no to it because we cannot be taking it from them because we are baby friendly. Financial sponsor of students and the presence of representatives to the health training establishment. Actually, they come and they want to teach about the formula. They say how good the formula is. It's next to breast milk. They want to come and show us how good it is and things. We have to say no to it. So what we did then is that we used the 10 steps as our vanguard. And it started with us having a hospital policy. The hospital must have a policy. And in our policy, we have to identify not promoting the infant formula. So therefore, we don't have it coded into the policy. We making breastfeeding care standard practice that once you come to work at this hospital, this is what you will find and this is what we will do. And we keep in track for the support of the breastfeeding. In step 2, staff competencies, we made sure there was training. There was training and training and training. And Ms. St. Hill can vouch the retraining and the retraining that is going on. Ever so often, we have to just put in some training. We just have to put in some training so that we don't lose sight of the initiative. And in step 3, we unfold it in the antenatal clinic. So we discuss the importance of breastfeeding for babies and mothers, prepare women in how to feed their babies. So we have a lot of teaching going on in antenatal clinic. We have sessions, we have posters. We have to do everything. We have to put it in their domain. We have to let them see it, let them know what it is about, because they're coming to be delivered. We expect them to know, because we expect that when they get to labor ward, that they will do what they're supposed to do. And this is where we really unfolds everything for them. The step 4 is very important if you want your hospital to be accredited as a baby-friendly hospital. We encourage skin to skin, so we do delay cord clamping, so the baby goes onto the mother, skin to skin. We have a cloth in the room, and we have a board in the room. We sensitize them from antenatal clinic that as soon as the baby is born and it goes up there, you know the time, because we say we don't want to tell you, oh, the baby ain't bothered with that and all of that. So we make sure that we teach them from antenatal clinic, so that when we get to this step that is so crucial to the baby-friendly hospital initiative, that they understand and they comply and they do what they're supposed to do. So we encourage skin-to-skin contact between the mother and the baby soon after birth. So the baby goes straight up, delay cord clamping, you get chance to get to know your baby, bond with your baby, and then we initiate the breastfeeding. So we make sure we document timing. They must understand the time, we sync the time, and these young people always got phones, so we make sure that they're on the same page that we are. So we write it up on the board so they can see it, the initials on the board and the time that this happened, because we want to make sure that we have adequate timing that these things happen. Step 5, the hospital support mothers to breastfeed. So we make sure we check to make sure they understand the positioning, understand what it entails to latch on correctly, and when we want them to do it the right way. And we give practical breastfeeding support. So we are really there with them so that we can let them show us what they're doing. And if they're not comfortable, then we redirect them and give them some clarity of how to breastfeed. And we help mothers with common breastfeeding problems, because some of them will say the baby don't like the left breast, they prefer the right breast, but then we were able to help them. In step 6, hospital support mothers to breastfeed by, no, we have a strict rule at the hospital, and that any milk that is ordered, any formula breast milk substitute is ordered for baby, it has to be medically ordered. So it has to be ordered by a doctor, and the midwives will question the doctor sometimes. And what we don't have is that it is not a free-on that you can just go down to procurement and order and bring the feed. We have it vanguarded at the intensive care unit where there's a book. So the treatment card goes down, they will get the appropriate feed that is required, and they sign on the book to say that it has been delivered and to the baby, so that when the assessors come, those are the things that they be looking for. See where you document all of this, because you must give an account of how much milk the hospital has purchased. Now we have an intensive care, and we also have the pediatric ward. So it's allowed that some milk will be coming in, yes. But can we have a high import bill to come into the hospital because we decide that each baby must get a top-up feed, as they call it? No, it will be weighed against the amount of deliveries we have and how much money we spend. But NICU book will give guidelines for the exact patients that deliver and upstairs and on the postnatal ward with the mothers. So we don't have a human bank, and we were part of the Belize, Brazil workshop in Barbados, but we have not signed on because we only have one hospital. So I guess it will take a little while before we can sensitize Bajans that they can give away some of their milk for a cost and give it to somebody else. That's another school of thought that we need to get into, possibly. And we make sure that we have, there will be some mothers that cannot breastfeed. We have created a room for the target mothers, preferably the HIV positive mothers. But what we do not label the room. So we do not advertise that. That is a room when you see patients going in there, oh, she can't breastfeed, she must have got HIV. We make sure that we can carry persons in at random just to make sure, like we will say, if they're done by the nursery, When you finish, I want to take you into the room. We want to have a one-on-one talk. We want to see how you're managing when you get home, how you manage. We start the conversation so that anybody going in that room is not really single out, because it is supposed to be the breastfeeding counseling room. That's what it's supposed to be. Rooming in, we will pass in flying colors with that because our babies are right next to their mothers. And if the baby has to be downstairs in NICU, there's visiting time, and they go down and they're able to sit with the babies. They also have a breastfeeding room down there for them. And we keep it real, the rooming in, we keep it real for the babies at the hospital. Helping mothers know when their baby is hungry. That is all the cues that they need. And we have put some posters up on the postnatal ward so that they understand exactly what we mean by cues. Because when you tell them how you know your baby hungry, sometimes they look at the clock and say, oh, the baby just get fed an hour ago, she can't be hungry or he can't be hungry. But we have to make sure that we specialize and tell them exactly what this is step is really about, and not limiting breastfeeding to times only. Counsel mothers on the use and risks of feeding bottle, teats, and pacifiers. So we do teach them, start from antenatal clinic, and then we have to get mothers who had successfully breastfeed to come back and give some pet talks to the mothers so that they understand that the journey is rough, but it can be done. And we explain to them all the benefits of it. Now, when they go home, our discharge is part of their planning. So when they go home, they're supposed to be going home knowing what to do, how to do it, and we have a free on, so they can call us back. We have contact numbers. We have midwives up there in the community, and they're paired with the ones at the hospital, and they give all the support to the mothers, and they know who they can call, and we give all the support that we can to them. So what we put in place that to help mothers to feel competent about breastfeeding is that we give them emotional support during labor. In that, well, before COVID-19, we still will be allowed to do it. We encourage them to bring someone to be with them, to give them that extra support, because they need that support when they're in labor. Now we manage the pain medication, because if we give them the Pethidine and they get drowsy, then they don't want to breastfeed. And we explain all that to them in antenatal clinic, how important it is I know sometimes they say the pain is so hard, they need something for the pain, but we explain that the pain medication that wouldn't stop the pain, it takes the edge off the pain. And then we explain to them the benefits of not taking it at such a late stage, because then you just want to bond with the baby, so you need to be alert so you can bond with the baby. We give them fluids during labor to make sure they keep hydrated. And we allow them to walk around. They have freedom of movements. And because at the hospital, they are individual rooms, so we give them their own space so that they feel comfortable in their own space. And early mother to baby contact, skin to skin. They have their baby with them all the time, so they know they look up for their baby, and that makes them feel real comfortable as well. And we assist them in facilitating the first feed. So the new updates that they have, because in 2009, the Baby Friendly Hospital was updated to integrate the code and the implementation, and we started the mother friendliness. And you will realize that if you follow us, the Clinical Hospital on YouTube, you will realize that when we became baby friendly, we did a YouTube video under the supervision of PAHO, and you will find that we use mothers who were successful in breastfeeding to come onto the site and give some support for the hospital initiative that we took. Care of the pregnant woman and the mother with HIV, we have incorporated into our policy, and it is a part of the department. And that is one area that you have to be very careful with, because in order to be assessed and to have your accreditation, you must include this category of patients. Obstetric emergencies, you have to know when it's an obstetric emergency, how you're going to still look after that baby. You still need the Baby Friendly Hospital Initiative to work for you. So you put all of that in your policy. You put it in your hospital policy, but then you go down to the department and you write it in so that everybody knows step by step what is done in the emergency. Expansion to other type of health facilities in the community. What you do is you do referrals, because we have the interaction and everybody is now on Zoom and they can make their call on WhatsApp and everything. They can communicate with us and we will pass them on to somebody. Somebody will come, and if it need visit, because sometimes you just need to talk, right? So we expand the type of health facilities in the community that will assist these mothers to breastfeed. And that's our journey from the Queen Elizabeth Hospital. Thank you.
Thank you so very much, Mrs. Harris. Certainly, it has been a pleasure walking the Baby Friendly Walk with you in the Queen Elizabeth Hospital as we journeyed along. It's a lot of work. It is not easy, a lot of teaching, and we pass the information on from one generation to the next. So we are working assiduously to make sure that we retain the BFHI certification. And I know COVID has come along and created a lot of problems for a lot of persons, especially with face-to-face teaching sessions and so, but it is not beyond us. And I want to thank you for that journey from a Barbadian perspective, which was quite different to, in some ways, especially when you compare a small island state like Barbados, where we have one main hospital, as opposed to some of our neighboring territories who had, for instance, like Jamaica, who had 22 hospitals, 4 private, 18 public, and several also in Trinidad. And so we have a lot of work to do. We're not just speaking among ourselves at this stage here for the BFHI, but right now we have 341 persons on board. And basically, I'm hoping that in our midst right here, it's not just midwives or persons associated, but persons who are part of the family structure out there that can provide training, that can provide a level of support at the individual level for all of those mothers. And as we know, we have not just acknowledged that there are simply 10 steps to attaining BFHI certification and compliance with the code, but we also have to look at issues where we have to be a mother-friendly institution and create an environment that is mother-friendly, and also to make sure that we support HIV mummies in their quest to make sure that their infant too get the optimal nutrition. So we're going to tie up our program with, like they almost say, save the best for last. And when you hear our final presenter for the evening before Q&A session, you will understand what an experience it has been to breastfeed. So our final.
Sorry, Marita, stop sharing, please. Go ahead.
Yeah. Stop sharing, Marita. Yeah. So our final presenter for the evening is Mrs. Bianca Edwards. Mrs. Bianca Edwards, she's going to share with us the experiences and challenges of exclusive breastfeeding, which we recommend for the first 6 months and beyond. And just a background about Bianca. Bianca is a child of the soil, as she calls herself, and she hails from the beautiful settlement of Waterford, Eleutheria in the Bahamas. She is a registered nurse and midwife. She is a certified lactation counselor, and she's a Zumba instructor. She has a lot of energy, and she also is an integrative healthcare coach. Now, Miss Bianca is married with a beautiful daughter called Brielle. I love that name, Brielle. Brielle is going to give you some jokes now. And also, Nurse Edwards is she has one single biological child, but she has certainly mothered several children. And this is simply because she wants to really instill a livelihood of being really having a God-fearing principle behind their development and to really mentor them and to help them to make really sound choices for life. Mrs. Edwards is a community-oriented person, and she really aims to have a healthier community through exercise and through moderating her lifestyle and introducing that whole concept to others. She's a visionary and she is intent on sensitizing all communities on the importance of healthy lifestyles. Her mission in life is to educate the clients that she encounters and the wider community about disease and complications. She wants to teach them about healthy lifestyle choices and about self-management of diseases and providing health coaching services. These initiatives are facilitated through consistent wellness programs, even in the midst of the dreaded COVID-19 pandemic. Nurse Edwards has initiated virtual exercises classes, and they're constantly ongoing. She has just recently completed her Master's of Science in Advanced Nursing, specializing in administration from UE, Cave campus, Trinidad and Tobago, and St. Augustine, I beg your pardon, St. Augustine, Trinidad and Tobago. And Mrs. Edwards has pledged to be a transformational leader through motivating and inspiring employees. She has recently published her book entitled Midwifery Mnemonics to Success. Her motto in life is, in association, is that association brings assimilation. Over to you, Mrs. Bianca and Brielle.
Good evening, good evening. Thank you so much for having me.
Hi,
So I was given the task to speak on the experiences and challenges that I had while breastfeeding Brielle, who hopefully stays in the room. All right, so at the time I got pregnant, I was a registered nurse, a pescatarian, still is. And on the 18th of October, 2013, I delivered a live female infant via C-section, and she weighed 5 pounds, 11 ounces. I wanted her to be exclusively breastfed, and I said, you know what, I can do this. So after delivery, baby roomed in with me until we were discharged, and her dad also roomed in with me. And that at that time was very, very supportive. As it relates to the time to be discharged, there were many challenges. And we all know that a challenge is any obstacle that makes breastfeeding difficult. And I feel the first 4 weeks of motherhood involve major biological, physical, and psychological changes that can cause challenges exclusive to this particular period. And challenges occur at different levels: individual, as it relates to the attributes of the infant, the mother, and the mother-child dyad; group level, as it relates to the mother's environment, such as the hospital stay, health services, the work environment, as well as the home environment; and last, the society level, where these factors, such as cultural norms and economic factors, play a part. The first night home, baby just cried. I was really tempted to purchase milk and a bottle. She just kept on crying. I purchased gripe water, as well as I resorted to dill seed, for those persons that are aware of these medications, so to speak, to help a crying or colicky baby, like we would say. I was really frustrated. I was exhausted and I felt like giving up. And I cried, but I still placed baby on the breast, and I begged my husband to go and buy milk, but he said, no, you said you want to breastfeed and we will do this. And we kept trying. So herbs, I feel, is the healing of the nation. And because I was on the pescatarian side of life, because I was a naturalist, I went out and I got some herbs, and their name was called nettle leaves. And it saved me from giving my baby cow milk. I actually pumped both breasts simultaneously, and every day I pump, I would get over 20 ounces each pumping session, labeled and refrigerated. And at that time, I couldn't connect what it was that I was seeing in terms of the fore milk versus the hind milk. And that is when I actually went into midwifery, that I kind of figured out and actually had an appreciation of basically what is fore milk versus the hind milk. So it was time to go back to work, and my husband insisted that I take Brielle to the nursery at least a week before going back to work. And I cried because I wasn't ready. I wasn't ready to separate from her. And that anxiety was something that I had to deal with. But eventually we got used to it, and it was time to go back to work, and it was easier for me. So I thank my husband for that. During the time of feeding, I would take the milk from out of the deep freeze. I would package it. I educated the teachers at the preschool on how to defrost, how to warm the milk. And I was like, make sure you don't put it in a microwave. Do not do that. Stir rather than shake. I know they got tired of me, but that was something that, you know, I wanted for my baby. And at some point, one of the ladies say, you stay right there. I can give this baby formula, or I'm gonna put some cereal in this. I was like, no, do not do that. I was really, really strict on that. I was back at work, and normally at lunchtime, you have an hour off. Rather than pumping, because my breast, of course, was full of milk, I went to the preschool, took off my shirt, and of course, cleaned the breast, and I just put her on the breast, and she sucked, and I burped her and, you know, went back to work. When I went home, I would pump and store. And to be honest, I had like a deep freeze and a freezer that was filled with milk that lasted for a year. It was time for me to apply to midwifery. And at that time, Brielle was 15 months and she was still breastfeeding. And after class, I would hurry home, bathe, and put the big baby on the breast. So my sister, who lived with me at that time, she always would shake her head and say, my Lord, Bianca, you need to stop. This child is too big for this breast. So after a while, I breastfed her for almost 3 years. And the only reason I stopped was because I realized that, my Lord, this is really a big child. You have laying on your lap, sucking these breasts, and you really need to stop. So I eventually stopped, and it was almost our third birthday, and I stopped. And I was so grateful to my husband for the support that he gave during my experience. In conclusion, overall, I felt as if I had a supportive supervisor who was also a midwife. And recently her daughter delivered. I think the child is about a year now. And she called me one evening and she was like, oh, nurse, I need some help. Please help me to encourage my daughter to breastfeed. I know you did so well in breastfeeding Brielle. And I did that for her. I'm thankful to my husband for being supportive, because if he wasn't there saying, okay, let's go ahead. You say you wanted to do it. I'm here for you. I think I would have resorted to the milk. My experience have allowed me to share with my clients and to encourage them to practice breastfeeding. Just recently, I got off the phone. One of my postpartum moms called and she's like, oh, you know, my baby has not passed in say 2 days now. And I'm just like, okay, so what are you doing? Are you breastfeeding? She said, yeah, but I given the baby lactogen. So me and her had a discussion about that. I said, you know what, just decide that, hey, you're not going to give that lactogen. You're just going to breastfeed and we'll talk tomorrow. But because of my experience, it allows me to be able to have that openness with my clients to know exactly what I've been through in order to encourage them. My experience also propelled me to investigate the challenges that women aged 18 to 19 years on the island of Eleuthera face while breastfeeding. So this is my research topic that I completed. And it also gave me the insight to give key recommendations to promote breastfeeding and to advocate and to make aware of those things that those women face as it relates to social norms and our subjective value system, to be able to influence the practice of breastfeeding. And that is my presentation and my experience and my challenges. Thank you so much.
I wish to thank you so very much, Bianca Edwards and Brielle, certainly. And you are truly a product of a successful BFHI story. Margaret Mears, you want to mute first, please? Margaret Mears. Margaret Mears, would you like to mute first, please? Thank you. Certainly a success story for a BFHI hospital, and then a parent with a relative and a committed partner, committed to the whole concept of exclusive breastfeeding and beyond. Thanks to Brianna, she can teach us that it is very workable and doable, but it is not without challenges. And at this time, we are going to open the floor for Mrs. Kayan Matthews to assist us along with our question and answer segment. And I'm quite aware of the time, and I want to thank you all, 332 at this time, for staying the course with us. We're going to open the floor, but remember, you have to complete the questionnaire and the segment towards the end to get your points at the end of the session. So over to you, Mrs. Kayan Matthews. Kayan, are you there?
Kayan, unmute, please.
I'm here, but the thing keep chipping in and out.
Okay, we can hear you now. Go ahead.
Yes, I am saying that the internet is unstable. So
Okay. Do you want us to Okay, so we'll look in the chat and look up some questions. Marcia.
Yeah, we had a question for, I will try at least to give each speaker one question, and if we have time, we could continue. So for Mrs. Bailey, there was a question. When we have a baby born with gestational diabetes mellitus from cesarean section, how can we supplement these neonates and maintain the standards and practices of BFHI?
All right, so thank you for that question. So it depends on what is happening to the mother during that stage, because no matter what condition, what medical condition depend, except for HIV, we promote breastfeeding for that mother. However, that is where the doctors will come in with the medical indications, and if the child needs supplement, that's where the doctor will play his role in prescribing that supplement for that mother. But once the mother can breastfeed her baby, that is what we recommend. And a C-section is no excuse to breastfeed your baby. I know that different mothers undergo different things, because I had 2 C-sections, and I successfully breastfed my baby. But different persons have different experience. So it depends on what is happening to the mother.
Thank you, Mrs. Bailey. And a question for Ms. Thomas. There were several, but as I said, I would ask one, and if we have time, we'll go to the others. Someone wanted to know the breastfeeding book that you spoke about. Will it be done in different languages? For example, Spanish and French, for the benefit of the Caribbean? And is there an app that will translate the ebook? And will the book be available for both nursing and medical students?
Very good question. We would, thankfully, we had those discussions when we met with Paho, who is doing the technical support for the production of the book. And in the with the ebook, they would have looked at doing the translation, because when we looked at the book, we thought not only of Trinidad and Tobago, but of the entire region. And so we did not come to a conclusive end in that, but we can continue to pursue the discussions to see if we can do the various languages. As far as the app is concerned, we didn't look at the app, but we really just look at making it available on the Directorate of Women's Health webpage from the Ministry of Health, Trinidad and Tobago. So we can also look at the app. We know it will be put on the Directorate's app. That is a work in progress, but for now, it will only be placed on the web page. Thank you. I hope I answered your question sufficiently.
Thank you, Mrs. Thomas. And one question for Marita. How can we get more doctors to be trained in the baby-friendly initiative?
The hospital, the training sessions that set up always invite doctors to the training, but then Ms. St. Hill would have done a presentation to the medical fraternity. So we will be doing another one shortly, because there'll be new persons coming in and they would be trained. But all they need to do is to contact the senior sister now if they want to be trained in the next lot that is going down. It's not hard to get into training.
Thank you, Mrs. Harris. And if I may, Shirley, for anyone who wanted to take this question, someone asked, what can we do to encourage the pediatrician, or to discourage the pediatricians on the ward from giving formula to the mothers? Anybody could take that?
All I can say is that we can discourage them because at the hospital, it's midwifery led. So the midwives would have an insight into why they're requiring the feed, and then sometimes you can persuade them, sometimes you can't, because they come up with some little things that you have to bite them sometimes and say, well, okay, let's hear why you want the formula. And then they are supervised by their senior, who is supposed to be on the same page that we are at. So therefore, sometimes we can persuade them, sometimes we can't. But we will still we still have to go back there and teach the mother and explain to the mother, because sometimes they just write at the formula, they don't really tell the mother anything. So therefore, or they will tell the mother, and the mother will come and say that the midwife didn't get you the feed, that the doctor required the feed, and it's a whole lot of things. But it has to be, you have to be really, really strong, because at the end of the day, it is a baby-friendly hospital, but you still want the optimal feed for the baby. So you have to look at the circumstances surrounding why he or she is ordering the feed, and why, you know, it is a priority right now, because it tends to be something that they need right now. Right now, that's what they make it feel like right now. Because also cesarean section babies go back to the recovery room and go on to the breast. So, you know, those are the challenges that we really face, and that's something we have to really look out for and work very close with, so that, you know, it's not identified, because it will be identified if the baby had trauma.
Thank you for that answer, Ms. Harris. And now one final question in the
Can I add something there as well? That is the importance of the policy. You know, in the baby friendly initiative, everyone talked about you must start out with a policy. So there's a hospital policy, then you must use that policy to direct the management, whether it's via the midwives, the pediatrician, or the obstetricians. You must use that policy. You must waive that policy in front of them when they are not on the same page.
Okay, so just one other question, and anyone can answer this. What should be done if a baby has to be separated from the mother, or if the baby has to undergo major surgery, or if the baby has to be flown to a nearby island for advanced care? I don't know who wants to take that question. Anyone?
I think Ms. Thomas, or was it Lily, talked about the new section of the policy of the baby friendly initiative that deals with ill babies, premature infants, and all of that good stuff.
What was the question again? Sorry. Could you repeat the question?
Question was for any one of the panelists. What should be done if the baby has to be separated from the mother, or if the baby has to undergo major surgery, or has to be flown to a nearby island for advanced care?
Does anybody, are you giving it to the panelists, or you would like one of us to answer?
No, I asked the panelists, any member of the panel to answer. Thanks.
Okay. Can I take that question,
Yeah, sure.
Marcia, because
Yeah,
we
sure.
have Trinidad and Tobago, so that's not a unique situation for us, being a Twin Island Republic. Usually, what happens is that the baby alone would be transferred. In the case now with COVID, I'm going to go from that COVID-19 perspective here now. In the case of COVID, the WHO has said that the mother and baby should be allowed to room in. So from that COVID perspective, if the baby is ill, or even if the mother is ill, now we have a neonatal intensive care unit, but sometimes babies still have to be flown across the Trinidad. And so sometimes the baby will come. What we want to do is continue the supply of breast milk, so that the baby can be given breast milk as much as possible, and allow the mother to visit when it becomes humanly possible again, so that they can be reunited.
Business not more we want to do. If you want it now one day, I will not do it.
Ms. Carr, could you mute your mic,
But
please?
I have to go to school and study and learn.
Could you mute your mic, please?
I have to do a pack your bag and go out there. So you don't die bird cook? I know that goes.
Shirley, could you mute Ms. Carr? Thanks.
To get a space.
So thank you, Deborah, for that answer. Shirley, do we have time for more questions? We are way past our time. Okay, some of the other questions I think were answered during the different presentations.
One more burning question, we'll take it.
Well, the only one I see here is about the fortifiers, milk fortifiers. I don't know if one of you want to address that. The question is, where did I see it? I just saw a question. Someone was asking about milk fortifiers. How important are they, or how necessary are they in the feeding of the infant?
Yeah. The question is, should breast milk be fortified?
Right. Yeah.
Mm-hmm. Anyone?
Bailey, you want to take that question?
Breast milk can be fortified if there's a need for it to be fortified. But sometimes, especially for a premature infant, depends on what is happening to that child, then sometimes the dietitian can recommend that breast milk be fortified. So if it needs be, yes, it can be fortified. So instead of using water to make the formula, you can use the breast milk instead. So it can be fortified. And there was another question. Someone was asking how often are hospitals recertified in Jamaica? It is every 3 years. That's the policy. Every 3 years, once you were certified baby friendly, you should be recertified in 3 years.
That's it for the questions, Malo. Sorry, we didn't have more time to go into more of the questions. Back over to you, Malo.
Thank you so very much. Thank you so very much, Mrs. Rolla. And that brings us nicely to the end of our session for tonight. I will hand you back over to our president, Mrs. Shirley Curtis. Dr. Curtis, I'm sorry, in a little bit, but I want to remind all persons that the form for the evaluation is in the chat. If you scroll through the chat, you will see it there just around 9 o'clock and a little bit earlier, perhaps. It's coming down as well. It's there about 9:03. If you look in the chat, you will see the evaluation form to be completed to ensure that you get your BFHI certification points for this evening. I want to thank you all for staying the course. We will be here for a little bit longer to ensure you all get an opportunity to click on that link and complete it before leaving the session. And I want to say thank you once again for a wonderful team. Most of you have been very gracious to allow us to proceed without too many interruptions, and you've been a good audience. You've muted your mics and all of that. You've been wonderful. So we are going to look forward to bringing you some more presentations from this educational committee, because we are committed to ensure that the education is not just staying in our small corners, but we as a Caribbean region will unite to make sure that we're all on the same page, to be a voice and a force for reckoning with. I want to thank you, just complete, and over to you, Dr. Curtis, should you want to say something else before we complete.
No, Marlo, I just want to say thank you to you for your, as you moderated. I thought you did a very good job tonight, as well as we want to say thank you to all of our presenters. As you would see, we had a regional response. We had Jamaica, Barbados, Trinidad, and the Bahamas. And this is what we're going to aim to do, get more persons involved in the education process, as well as be involved in our education committee. So you might just have to moderate like Marlo or do the questions like Marcia. But we like to get involvement from across the Caribbean in our educational sessions. I just want to say that we had up to 347 persons on the chat tonight from 13 different countries. And I'm going to call the countries. And if you don't hear your country, you need to put it in the chat. So we want to say thank you to British Virgin Islands, Trinidad and Tobago, Jamaica, Grenada, Guyana, the Bahamas, and some people were very particular from the Bahamas, but I saw Eleuthera, Cat Island, Exuma, Nassau, and Grand Bahama. Dominica, TCI, that's Turks and Caicos Island. We had St. Kitts and Nevis, we had St. Lucia, we had St. Vincent and the Grenadines, we had Antigua, and we also had Belize. So if you didn't hear your country's name, please put it in the chat, and we want you to spread the word, because once you are in our network, when the next webinar will be done, we will send it out to you. And so it's now your job to send it out to those persons who you did not see in the chat tonight. Every midwife that you know. And of course, on a topic like this, you didn't really have to be only a midwife, because breastfeeding is everybody's business, right? So we say thank you very much. The link is in the chat several times. Please get it, save it to your browser, so that if you're not going to answer it right now, I suggest that you do, but give us a month, because like we said, it's 250 persons. So it takes the secretary a little bit of time to get those certificates back out to you. We are going to give you until the end of the month. So today is the 28th. We're giving you until the 30th to fill this form out, and then it is closed. So you have 2 days to fill out your form, and then wait for the month of October. And by the end of October, if you filled it out and you did not hear from us, please email the Caribbean Regional Midwives Association, and they will respond. Okay, so thank you very much, and have a wonderful evening.
Curtis.